So my senior research project was on the effects of hyperbilirubinemia-induced jaundice on infants compared to its effects on adults. So just to break down a couple of background terms and relevant knowledge to the course of the study, jaundice and hyperbilirubinemia are two of the main focuses of my research. Jaundice is a medical condition that affects a majority of all neonates. Neonates are newborn infants, and it is characterized by a distinct yellow coloring of the skin, which is caused by a buildup of bilirubin in the bloodstream. Hyperbilirubinemia is the buildup of bilirubin in the bloodstream, which can be caused due to a variety of factors. So the reason why I wanted to do my research on this topic is because over 50% of all children born are diagnosed with jaundice, 56%. And if left untreated, jaundice can have a profound medical impact on children for the rest of their life. It can lead to impaired motor, cognitive functions, and in some serious situations, it can lead to death. There's been a lot of research on infant jaundice designed to mitigate these factors. They were done by a subsection of the National Institute of Health called the National Institute for Biotechnology and Information. However, there has not been a lot of research on adult jaundice treatments. So I sought to bridge the gap between information on infant jaundice treatments and adult jaundice treatments. So the way my study was conducted was through a lot of analyzation. So whenever a baby is born, they are given what is known as a transcutaneous bilirubin test. You can see what one looks like in the picture. And what it is, it's where a medical professional takes a scan of the infant's skin, and it gives a rough estimate of the bilirubin level in the baby's bloodstream. Bilirubin is on a scale, it's measured on a scale from about 0 to about 50. And the higher the number, the greater the jaundice. Most people live our lives around a level of 1 or lower. Some infants, whenever they're born, can get a jaundice level of up to 30 or 40, which is shocking. If the medical professional thinks that the bilirubin level is a little high or the reading seems off, they can then administer a blood analysis to the infant, which is a blood draw taken down to a laboratory for analysis to determine what the actual bilirubin level in the bloodstream is. Adults are treated in much the same way. Generally, adults, when they're diagnosed with jaundice, are given a transcutaneous bilirubin test. And then if the doctor gives them a blood draw test, it is almost always for multiple purposes. Because jaundice often occurs as the result of different underlying medical factors, the blood draw, while analyzing the bilirubin level, will also analyze trying to find the source of the jaundice in the patient. So the materials needed were the transcutaneous bilirubin test kit, which is the machine down in the bottom, and then any tools, medical devices needed for a blood draw, standard needles, hypodermic needles, collection materials, and then the analysis tools in the lab. In addition, I used the Riverside Regional Medical Center data banks to get additional information on the number of infants who were diagnosed with jaundice, the number of adults who were diagnosed with jaundice, and the treatment methods for all of them. And then my treatments also used UV light to complete the comparison of treatments between adults and infants. So the expected results that I had is that treatment won't be applicable from both infants and adults. So infants generally have higher bilirubin levels, even if they're jaundice compared to adults. You can see it in the graph in the lower right, where above a certain range, the infants are at high risk. Below a certain range, they're at low risk. And then there's an intermediate range in between both of them. Adult jaundice patients never get anywhere close to that level due to the nature of the jaundice. As a result, treatment methods will be different for adults and infants based on the underlying condition. As a result, treatment will not be able to transfer from adult treatment methods to infant treatment methods, and vice versa from infant treatment methods to adult treatment methods. As I expected, whenever I ran my research from both patients and the Riverside databanks, this was the result that I found. Infant treatment methods only worked on infants, and adult treatment methods only worked on adults. This was not due to any treatment being less efficient than the other. It was due to the underlying condition in infants and adults being different. There are some situations in which genetic disorders make it so that infant treatments would work on adults. However, those are very rare. Riverside did not have any recorded cases of those genetic mutations in the past year, 2 years, and they only had a couple of adult jaundice cases recorded as well. However, they had about 3,000 to 4,000 births over the past year, and about 50 to 60% of those infants were diagnosed with neonatal jaundice. All of them were treated in pretty much the same way. They were given the bilirubin, transcutaneous bilirubin scan. If it looked unfavorable, they were given a blood test, and then they were treated with special UV lights to break down the bilirubin. The chart that I have on the screen shows why treatment methods are unable to be transferred between adults and infants. Sepsis is a blood infection, which can lead to jaundice because bilirubin can't be processed. Unknown sources of jaundice, which are generally neonatal jaundice, can be treated using UV light. You don't treat sepsis the same way you treat neonatal jaundice. You wouldn't use UV light to treat sepsis. This isn't due to UV light being an inefficient treatment for jaundice, it's due to sepsis being more difficult to treat. It's the same principle throughout my research, where adult jaundice patients generally had more difficult and more life-threatening conditions that needed to be treated and needed to be resolved before the jaundice was able to be treated. So I wanted to say thank you to my mentors, Dr. Elias Tasema, who's in the picture with me, and Dr. Dave Amaker. They were both very, very, very helpful on my research. They answered any questions that I had and gave me a lot of good information. I wanted to say thank you to the Riverside Regional Medical Center for allowing me to use their campus for research purposes, and the Neonatology Intensive Care Unit for allowing me to conduct my specific research and data gathering there. I also wanted to say thank you to Ms. Vobrak for coordinating the research opportunity that we had at the Governor's School this year. And so if there are any questions, please put them in the comment box below, and I will respond to them using the as best information as I can. Thank you.